Okay. Welcome to our next episode of 7 Minutes with an Expert for Liver Fellow Network. Today, we are fortunate enough to have Dr. Jessica Mellinger. She's a transplant hepatologist at the University of Michigan, and she focuses mainly on alcohol-related liver disease and specifically on novel interventions to manage alcohol use disorder in a multidisciplinary fashion. Thank you, Dr. Mellinger, for joining us.
Great. Thanks for having me here. Appreciate it.
So as you know, this is a format where it's, a quick 7-minute interview just to give a flavor of the types of things that you're interested in. So our watchers can learn and learn a little bit about what you do.
Great.
So we'll just get started, and I'll just start my timer so that we're trying to keep things on time. I personally wanted to pick your brain a little bit about the management of alcohol use disorder post-transplant. I think we focus a lot on it pre-transplant, as we should, but it's a disease I think that recurs just like NASH, just like autoimmune hepatitis. So maybe you could just give us your quick thoughts on, does it recur? And if it does, what does that mean for the liver?
Yeah, it absolutely does. AUDs, alcohol use disorders, tend to be chronic over a lifetime. So you can see symptoms kind of wax and wane over the years. And we do know that after transplant, people will drink, and sometimes very heavily again. I think one of the best studies that was done of this was around, I want to say 2008 by Andre DiMartini, that looked at this prospectively in a big cohort of post-transplant patients, looked at alcohol use prospectively and found that about 50% of patients would drink at some point in their post-transplant life. About, I would say, maybe 25% would drink heavily, and that's been borne out in other studies as well, that shows that about a quarter, you could think about a quarter, will go back to the kind of heavy destructive drinking that can actually destroy the graft and cause loss of life. And it absolutely matters, because you can see graft loss because of alcohol use after the transplant, and it can happen fast. So you can see people get cirrhosis in 5 years after a transplant if they're heavily drinking. So it isn't as if people are going to have 30 years on this other liver, so they can just go out and drink and get another 30 years. And hey, if I'm 60, it doesn't matter. It does matter, because you can definitely see, problems with the graft, but also the same problems you get with alcohol use: falls, head bleeds, car accidents, just the whole litany of problems that people get when they drink heavily.
Okay, so you alluded to maybe that there's a high percentage of people who drink, but if you sort of break it down into how heavily they're drinking, it's sort of different percentages. And so, we hear about slips or heavy drinking or binging. So maybe you could briefly just kind of give an overview of what those different things are.
Sure, yeah. So the terms that we use are, the two big terms for recurrent drinking are slip versus relapse. And slip is when someone drinks but goes quickly back to total abstinence. So they drink and they're like, oh, after 2 or 3 days, they kind of get it, and they're like, oh, I got to get help. Relapse is when people go back into drinking regularly and frequently heavily over a longer period of their time, and over a longer period of time, and there is no immediate return to abstinence. So there's no alcohol amount that we put on those things. You don't have to be drinking heavily to be considered a relapse. If you're drinking consistently and over time, continuing to have more issues with alcohol use disorder symptoms, that type of thing, then you're in a relapse.
Okay. So then, I don't know, you can maybe tell us your practice or what you think should be done, but, is checking, periodic biomarkers for alcohol use post-transplant something that so we don't sort of do that here, but is that something that you think everyone should be doing, or?
Yeah, absolutely. I think there's basically 3 things that we can do and that we should be doing to catch folks or to pick up when people are using alcohol, so that we can get them into treatment and stop a slip from becoming a relapse. The first is to ask them. So you, as the hepatologist, asking at every time you see them, even if it's 3, 4, 5 years out, hey, how are things going with alcohol? Have you had any slips, any use of alcohol at all? Any urges to drink? Sometimes people will know urges come up to drink. So you can ask. Use audit Cs. Use a standardized questionnaire, and the audit C is a quick, easy 3-question questionnaire that we use pretty frequently, that the VA uses, that it can be programmed into your electronic health record as well, so that you can just do it automatically. And we do that here at Michigan. And then the third thing is biomarkers and checking alcohol biomarkers. There's a reasonable percentage of discordance in transplant patients. I want to say on the order of 20 to 30% in the pre-transplant listing period, where you have positive biomarkers when someone has said they're not drinking. Are there false positives? Yes. And so we never want to delist someone or anything like that solely on the basis of a positive biomarker, but it should prompt us to talk to our patients and say like, hey, what's going on? This popped up positive. I would say also you want to make sure that your patients know that they're going to be getting these biomarkers checked. And so whenever I see someone, I really normalize that for them. Like we check this on everybody where alcohol is part of their liver disease. It's not because I think you're lying. It's not because I think you're not telling me the truth. We just get it like, you check an A1C or a blood glucose on people who have diabetes. We want to see how things are going.
Yeah, I really like that point. I think I've seen at various places, the feeling of let's just add it on to the blood, but, to sort of don't tell them, get a PET test or something like that. And, that I think sort of, it feels like that only perpetuates that feeling of I can't be honest, from the patient side. And so, I like that point of, just tell them, this is what we're checking routinely like we would for anybody else.
Yeah, you want to preserve that relationship with your patient. My psychology and psychiatry colleagues in mental health are very aware of a fact that we are often not aware of, and that's that the quality of the relationship between a patient and their provider is in mental health often the strongest predictor of a good outcome for therapy. It's how good is that relationship. So doing things to strengthen that relationship, making sure that you establish trust, that your patients know that they can come to you if they are struggling with alcohol use or they're feeling like they have an urge. Kind of normalizing that in a way, it's kind of a fine line to walk between saying everybody's going to relapse, but not everybody does, right? So, but saying like, hey, sometimes people do, sometimes they don't, you're not a weak person, you're not a bad person, you're not doing something wrong if you're feeling, some of these things, or if you, God forbid, pick up a drink, just let us know right away because we can help. And that's sort of the attitude that, you want to try to cultivate for your patients, that you want them to come to you when they're struggling.
Right. Another thing that came up recently was, we had a patient who was pretty sick prior to transplant and thus didn't really get the opportunity to fully complete the treatment for alcohol use disorder that we might recommend. So then he gets transplanted and then comes to us a few months later and he feels like $1 million. And, he's like, I'm not going to go back to drinking. I feel great. And and we know that, like, as you mentioned, the risk of relapse is still very high. And so, in that moment, it's on us to sort of teach them and explain to them why it's still important to go through the treatment if they can. And so I guess my question is, should all hepatologists have some training in motivational interviewing?
Yes, they should. Yeah, absolutely. I think this is a perfect example of when motivational interviewing, or MI, is, a great technique. And it's really it's not even really a technique. It's more of like just a spirit of how we approach our patients. Instead of telling them and shaking our fingers like, you should understand that relapse can happen, we want to offer that information in a respectful way and in a way that they'll receive. So if there's resistance to, or kind of like ambivalence about, continuing alcohol use treatment, continuing practicing, relapse prevention behaviors, that we can, again, work with them on that to kind of come to their own conclusion internally that it's the right thing to do. I've started using an NFL analogy. I don't know if it's helpful, it might be, but I view a lot of people react to the term therapy and react to the idea that they have to see a psychiatrist and stuff. These are very stigmatized things. So I talk to people about like, hey, in the NFL, if they're at the Super Bowl, these guys are the best of the best, right? They are the tops in their profession, in the nation, if not the world, and sometimes for all time. And who's on the sidelines helping them? Coaches. And lots of coaches. These guys are getting coached constantly, but they're so good already. Why would they need coaching? But they do it to keep their skills up, to stay on top of their game, to be as good as they can be. And that's kind of what I tell my patients is like, you guys are at the Super Bowl. Like, you're there. You got the skills. You did it. Like, let us help you continue to coach you through, your life forward so that you don't, so that you continue to have a good life, and not have to deal with alcohol again.
That's great.
Spin it positively. These people have done phenomenal work, right, to get through a transplant to get to that post-transplant period. So really, acknowledging the reality of all the good traits and good qualities that your patient, for example, brought to the table in being able to get through this incredibly stressful thing, not drink, like absolutely build on that, be optimistic. Like, I think you can do it, but here, let us help you, man. Like,
That's great.
I don't know much about football, but you're the
The
Tom
Tom
Brady.
Brady of
You're the Tom Brady of, no, it's like, I'm going to show really quickly how bad I am at football, but
At least you chose a Michigan guy.
there you go. Yeah, exactly. Like that's the extent of my football knowledge right there. You just heard it all.
I just made a mental note of that, and I'm gonna use that in the future. So, unfortunately, our 7 minutes is up, but that was, I think, really enlightening and nice to sort of just talk through your thought process for that. So, thank you. But even though our 7 minutes are up, I know that you and your group have done some pretty novel and really exciting things with multidisciplinary management of patients with alcohol use disorder. And so I'd be remiss if I did an episode like this and didn't give you a chance to just give a quick 1 minute elevator speech about what you guys are doing over at Michigan.
Absolutely. Well, we founded one of the nation's first non-transplant multidisciplinary alcoholic liver disease clinics. And so we brought together myself, a hepatologist, a psychiatrist, psychologist, social worker, and nursing together in a co-located clinic. And we see patients and have been seeing them now. We're in our 3rd year. These patients have more advanced liver disease. So we see alcoholic cirrhosis, alcoholic hepatitis patients. And we see them and put together a really integrated plan that integrates their liver disease care with their psych care, with their alcohol use disorder care. It's been very successful. We really enjoy taking care of these patients. It's incredibly rewarding. We have patients who, maybe drop off the face of the earth for a year or so, but then come back when they're struggling because they remember, that we, we're accepting of them and non-judgmental, and that, it was a clinic that doesn't require perfection, but just wants people to succeed. So we've been really, really excited about it. And we've been talking to a lot of different people around the country too about starting similar clinics in their own locations. So I think this is, kind of an idea whose time has come, and people are seeing, that as liver doctors alone, these patients are really complicated. They have a lot of psychosocial complexity about them. And so having our psychiatry, psychology, social work colleagues, working with us as a team to take care of these patients is really necessary, but also just really rewarding. It's a great opportunity.
That's really exciting, and I congratulate you guys for doing that. And so that's it. And I like to end these episodes with one non-medical question. And so as someone who also spent some time in Ann Arbor when I was there for undergrad, it's near and dear to my heart. So I would like for you to tell our viewers what's one thing that would be your favorite part about Ann Arbor.
My favorite part about Ann Arbor, oh wow, that's hard because there's a lot of really good stuff. I love the seasons here. I really love the changing of the seasons. We're in autumn now, and the leaves have kind of all fallen, but that autumn time frame with beautiful leaves, apple cider and donuts at the cider mills, and walks in the woods. It's a really lovely, beautiful place all year round, but I'm particularly partial to autumn. So
it really is. Maybe not the winter when it gets snowy, but
yeah, when it gets snowy and cold, like that January, February time frame is kind of like, maybe
it's worth it. It's worth it.
Yeah, but it's definitely worth it. It's great. It's worth it for spring, summer, and fall for sure.
Yeah. Okay. Well, great. Thank you so much for joining us.
Well, thank you for having me. I appreciate it.
All right. You take care.
Bye now.
Bye.